colonic carcinoma. It is not there in the presentation, and I will just verbally communicate to you. For colorectal carcinomas are you screen whether is it a male or a female. You usually screen the elderly population, and the screening for the elderly population is greater than 65. There's a guideline you can see in the NICE guidelines. The colonoscopy, not the colonoscopy, screening for the colorectal carcinoma, when you should do it. You should do it if the patient age is greater than 60. If the patient is greater than 60, you are going to screen the patient for colorectal carcinoma. What is the modality? You will do it with FOB, fecal occult blood. So this is the test that you will do it from the stools. You do these FOB for all the elderly patients. You screen them up whether they have the problem. What is the problem? Any weight loss or constipation, new onset constipation, vomitings, maybe abdominal pain, persistent abdominal pains, or abdominal mass per se. These are the things that can hint you towards colorectal carcinoma. But I'm talking about the general population. I'm talking about the screening tools. So for this, the age should be 60 and above. The modality is FOB, fecal occult blood. And with this FOB, you then need to see whether what is the result of that FOB, fecal occult blood. If the fecal occult blood is, they also divide the FOB test into 3 or 4 categories. One is that you do FOB, and FOB is normal. This is okay. You screen the patients with no colorectal carcinoma. Number 1. Number 2 is 2 to 4 spots. When there is blood spots. So if there are 2 to 4 blood spots, you need to see whether the patient has is high risk factor, is high risk or not. This is called intermediate or borderline. You still want to repeat it after some time to see whether this patient still have this or not. So this is called borderline, 2 to 4. Greater than 4 spots, they will give you the criteria that maybe he's at high risk of developing colorectal carcinoma. So this patient requires referral for colonoscopy. And on the basis of that colonoscopy, you then again decide what kind of management plan you are going to do, because colonoscopy will give you normal result, will give you the same as CIN, will give you normal result, moderate result, polyps, maybe because colonoscopy, with the colonoscopy you will get 2 types of result. One is the gross morphology of any kind. Number 2 is histopathological report. So based on the gross morphology and the histopathological report, you are going to decide your management plan, whether you want to do repeat colonoscopy, or if the colonoscopy is okay, you need to step back and do the FOB, because FOB is also a screening tool. The screening tool is different and diagnosing tool is different, and then managing or not to manage, these are all 3 different questions that need to be answered. So it's not just 1 + 1 2. First stage, you need to screen all the patients with FOB, for all the elderly patients, by the way. This is going to be another opportunistic care for this colorectal carcinomas. The second thing is, if you diagnose, when you do FOB, if it is positive, you refer for colonoscopy. If the patient is negative, you repeat colonoscopy. Negative, then okay, 3-year or 5-year recall. If it is borderline, again the problem is with the borderline cases. Borderline cases, you need to repeat 2 further reports, and 2 further reports will give you the same borderline result. Then this result is going to qualify the patient into colonoscopy, and on the basis of that colonoscopy, you will decide that you refer the patient for the colonoscopy if you have 2 borderline results or 1 positive result. One positive result, colonoscopy referral. Two borderline results, positive, go for colonoscopy. Negative, okay, recall. 3 years or 5 years follow up till the age of 75. After that, there is no need to do these kind of screening tools, because you are not going to do something aggressive to those patients who are very elderly in any way. So there is no point in screening those patients for colorectal carcinomas. You won't be able to do any invasive procedures on them. So for the colonoscopy, this is all the geriatric patients that are coming to you. You are doing these colonoscopic results. This will again add to the opportunistic care that you are giving to the patient. Probably the patient is not coming to you with these things. Some the problematic patients are not those who has these evident features, like the patient is having weight loss, the patient is having abdominal mass, the patient is having new onset constipation. So these are all things that suggest that okay, the patient may have colorectal carcinoma, and you should be screening them patient up for FOB. But irrespective of these symptoms, you should screen all the elderly patients for colorectal carcinoma. All right. So these are just the screening tools. Obviously, there are a lot of other screening options depending on the cases. You should screen for diabetes, you should screen for hypertension, you may want to screen for depression if it is relevant, you may want to screen for obsessive compulsive disorders if it is relevant. So depending on the patient's situation, you should screen for different things. These are just one of the examples of how you are going to screen the patient up. You should think the patient as an opportunistic care. What are the opportunities that you will have it, and then you can intervene the patients in the caregiving management plan. All right. Okay. So we are done with today's presentations for the screening and preventive tools. Is there any questions up till now? Yes. If the patient has the family history is positive, then you do not wait for 60 years. 60 years of age, you will do before, maybe 30 or 35, depending on which kind of cancer the patient has. You may want to do colonoscopy right away. If the patient has first degree relative who has colorectal carcinoma, there are first degree relative, there are second degree relatives. If the patient has first degree relative, you go directly to the colonoscopy directly, not do FOB, fecal occult blood test. So depends on that. Obviously, high risk patients will screen earlier. Okay. Any questions from the female side? All right.